Good morning. I'm Dr. RAMNEsh. Today we'll discuss about pediatric operative dentistry. Contents include introduction, objectives, indication, classification, principles of cavity preparation, ART, matrices and wedges, conclusion and references. Definition: according to Stedman, operative dentistry is the art and science of diagnosis, treatment and prognosis of the defects of teeth that do not require full coverage restoration for correction. Such treatment should result in the restoration of the proper tooth form, function and aesthetics while maintaining the physiologic integrity of the teeth in harmonious relationship with adjacent hard and soft tissues, all of which should enhance the general health and welfare of the patient. Operative dentistry is a subject that deals with diagnosis, prevention and treatment of problems and conditions of natural teeth, both vital and non-vital, so as to preserve the natural dentition and restore it to best state of teeth, function and aesthetics. This definition is according to Gilmore. Objectives are to repair or limit the damage from caries, to protect and preserve the tooth structure, to re-establish adequate function and restore aesthetics, to provide ease in maintaining good oral hygiene. Pulp vitality should be maintained whenever possible. Classifications are according to G.V. Black. Class 1 are all pit and fissure lesions on the occlusal surface of premolars and molars, lesions on the occlusal two-thirds of the facial and lingual surfaces of molars, lesions on the lingual surfaces of maxillary incisors. Class 2, lesions on the proximal surface of posterior teeth. Class 3, lesion on the proximal surface of anterior teeth without involving the incised ledge. Class 4, lesions on the proximal surface of anterior teeth involving the incised ledge. Class 5, lesions on the gingival third of the facial or lingual surfaces of all teeth. Class 6, lesions on the incised ledges of anterior teeth or the cuspal tip of occlusal posterior teeth. Pins modifications. Class 1, cavity involving the pit and fissures of molar teeth and buccal and lingual pits of all teeth. Cavities involving proximal surface of molar teeth with access established from occlusal surface. Class 3, cavities involving the proximal surface of anterior teeth which may or may not involve a labial or lingual extension. Class 4, cavities of the proximal surface of anterior teeth which involve the restoration of an incisal angle. Class 5, cavities present on the cervical third of all teeth including proximal surface where marginal ridge is not included in the cavity preparation. Next is Stedman classification. Simple cavity, a cavity involving only one tooth surface. Compound cavity, cavity involving two surfaces of the tooth. Complex cavity, cavity involving more than two surfaces of teeth. Mountain Hume classification is according to the site and size of the lesion. Site 1 is the pit and fissure on occlusal surface. 2 is proximal areas below the contact point. 3, cervical 1/3 of the crown. And size 1 is with minimal involvement of dentine. Size 2, moderate involvement of the dentine. Size 3, splitting of cusp or incised ledges, and size 4 is bulk loss of tooth structure. Cavity preparation according to Stedman is a mechanical alteration or defective, injured or diseased tooth in order to best receive a restorative material which will re-establish a healthy state for the tooth, including aesthetic correction where indicated along with normal form and function. Principles of cavity preparation include initial cavity preparation that includes outline form and initial depth, primary resistance form, primary retention form and convenience form, and final cavity preparation, removal of the infected dentine, pulp protection, secondary resistance and retention, finishing of the enamel walls and cleaning of the cavity. Outline form is defined as placing the cavity margins in position which will occupy in the final preparation except for the finishing enamel walls and margins, preparing an initial depth of 0.2 to 0.8 mm pulpally of dentino-enamel junction. Principles are all friable or weakened enamel should be removed, all folds should be included in the cavity, all margins should be placed in a position to afford good finishing and margins of the lesion. Outline form include external outline form and internal outline form. External outline form is established first to extend all margins into the sound tooth tissue while maintaining an initial depth of 0.2 to 0.8 mm into dentine towards the pulp. During tooth preparation, the margins of the preparation not only extend into the sound tooth tissue but also involve adjacent deep pit and fissures in preparation. External outline form, it should consist of smooth curves, straight lines and rounded line and point angles. Enamel which is unsupported by dentin as well as demineralized enamel should be removed since it is liable to fracture. Internal outline form, it includes the relationship of occlusal walls from cavo-surface angle to the pulpal floor. Preparation depth should be at least 1.5 to 2 mm. Factors affecting outline form and initial depth form of tooth preparation: extension of the caries lesion, proximity of the lesion to other deep structural surface defects, relationship with adjacent and opposing teeth, caries index of the patient, and need for aesthetics. Features for establishing a proper outline form are preserving the cuspal strength, preserving the marginal ridge, minimizing buccolingual extension. If the distance between the two folds is less than 0.5 mm, it should be connected, limiting the depth of preparation 0.2 to 0.8 mm into dentin. Rules for making outline form: extend the preparation margin until the sound tooth structure is reached. Restrict the depth of the axial wall 0.2 to 0.8 mm into dentin. Axial wall should be parallel to the external surface of the teeth. In class 2 preparation, place the gingival seat apical to contact but occlusal to gingival margin and have the clearance of 0.5 mm from the adjacent tooth. The extent of the preparation margin should include all pit and fissures which cannot be managed by enameloplasty. Limit the depth of preparation to 0.2 mm into dentin through the actual depth. If indicated because of aesthetic reason, like make the preparation as conservative as possible. Primary resistance form, it is may be defined as the shape and placement of the preparation wall which enable the restoration of the tooth to withstand without fracture masticatory forces delivered principally along the long axis of the teeth.